Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar on acne scarring, what to do. Our speakers this evening will be Dr. Charles Lind, who is Chief Medical Director, the Lind Institute of Dermatology and Lind Derm Research, and Associate Professor at the University of Toronto, Department of Medicine. Also, Dr. Geeta Yadav, who is Medical Director and founder of Facet Dermatology, Division of Dermatology at the University of Toronto, and Clinical Adjunct at Women's College Hospital. We'd like to thank our supporter, Cipher Pharmaceuticals, for making this educational event possible. Before we begin, a couple of tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues or if you would like to ask a question to our faculty, please submit your question using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you. We greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be emailed to you. Again, if you have any questions, please submit your questions using the question chat pane on the right-hand side of your screen. And I wrote a little note in the chat there that you could see where you need to type in your questions. As a disclaimer, the opinions expressed in this presentation are that of the presenters. They do not necessarily reflect the opinions of Cipher Pharmaceutical. So without further ado, I am going to pass the floor virtually to Dr. Lind.
Thank you very much, Roxanne. So welcome to Acne Scarring, What to Do. And this is another one of our series about talking about acne, one of the most common diseases that dermatologists and actually family doctors treat. Tonight, we're going to talk about really why you want to prevent the acne scarring. However, unfortunately, if we don't treat it early enough, you do get scarring. And Dr. Yadav is going to talk about all the tricks of the trade to make that scarring much better. Just a second here. All right, so epidemiology of acne. First, it's the most common disease in the United States, skin disease. Impacts about 50 million Americans. Global presence around 10%. Estimated costs associated with treatment and productivity lost around 1.2 billion. And again, 20 to 40% of females over age 25 have an acne recurrence. This is certainly a trend that certainly I'm seeing in my office. More women getting acne in their 20s and into their 30s. Now, what about Canadian figures? This varies. There's figures that it's roughly 2 million Canadians at any one time, or even up to about 5.5 million people, Canadians having this. It certainly is very common in the adolescents. And as I mentioned, this is going into the 20s now and into the 30s. There's certainly emotional and social impacts of acne. And again, scarring occurs in some degree in about 95% of cases, but more frequent in severe scarring. So treat early, and scars can develop even early within 12 weeks. If you see any hint of scarring, you need to treat these people aggressively. These are the risk factors. Family history: if your parents had bad acne, you're going to get bad acne. Again, the age grouping is not just adolescents, but moving on into the 20s. People with a higher BMI. Again, this has to do with possibly polycystic ovarian syndrome and skin type. And in particular, we're seeing more acne in the Black and Hispanic women than other ethnic groups. This has been borne out by several studies south of the border looking at this. Again, acne, leading dermatological diagnosis in skin of color, and particularly they get post-inflammatory hyperpigmentation in these darker skin Fitzpatrick types, and an increased risk of sequelae, not only this chromia, but also keloids. And keloids in particular, Dr. Yadav's going to tell you, are very difficult to treat in these acne patients. I think we have to recognize that this can be a chronic disease, long course, pattern of reoccurrence, again, acute outbreaks, slow onset. Psychological and social impacts. And there's good evidence that acne can persist in the adult years in as many as 50% of adults. So it should be approached as a chronic disease. Post-acne scarring. Again, as I mentioned, up to 95% of our patients with acne get some degree of acne scarring. They often result from dysregulated collagen production. And again, the peak of this scarring usually is 14 to 19. But as I mentioned earlier, I'm seeing this increasingly in young women that are in their 20s, even in their 30s, getting scarring. Obviously, they want this scarring treated. There's certainly a psychological burden of disease, low self-esteem, anxiety, depression, particularly when this is occurring in your teenage years and into your 20s when you're dating and finding a mate. These give you a number of different emotional distress. And I've even seen people become potentially suicidal over their really bad acne. They don't want to go to school. They don't want to go to work. And again, in a survey, found that 30% of patients reported negative comments about their scars, and then 10% verbal and physical abuse relating to these scars. So certainly a problem that we need to address and hopefully prevent. This was something I dug up in preparation for the talk. Bridget Drino, who is sort of a princess or queen of acne in Europe, has done a lot of work around acne. She's well known in the acne field. And she did a survey, an online survey looking at this. And again, the first thing, if they had scars, they would notice this versus only 8% looking at clear skin. So it was the scarring that was drawing people's attention. Again, people with scars seem to have less likely to have a promising future, less likely to be considered attractive, confident, happy, healthy, and successful. And again, having even the scars, more likely to be perceived as insecure and shy because of those scars, which is natural. So prevention, as I mentioned, is a key. Again, ameliorate this acute psychological distress and treat them early. Well, luckily in the acne field, we have a lot of different options, not only topicals, but orals. And you can see these are some of the things that are on the market in Canada to help prevent that scarring. So treat these patients. You can't just say, you know, and I see a number of times I've seen something, child for a mole or nevus or something else on the skin, eczema, and I say, oh, by the way, I notice you've got a fair amount of acne. Do you want to treat it? And initially, sometimes they say, oh, no, that's just going to go away, no problem, and everything else. And I take the bull by the horns and say, listen, you need to treat this because I don't want you to have scars. Because if you get scars, it's going to be something that's going to be difficult for me or others to treat. Similarly, oral treatments, and I boldly put in isotretinoin. This has been around since 1982, I believe, in Canada. So 40 years, roughly, or plus 40 years, and been a godsend. So initially, people were afraid to use this drug. We now use it like water, if you want to say, because it really makes a big difference in preventing this scarring in people. Of course, some people will use antibiotics, and we have hormonal treatment, particularly spironolactone, we use for a number of patients. And again, if you have something that can treat each of these different modalities in your regimen plan, alternation in the keratinization, sebum production, molecular colonization, and a release of the inflammatory mediators, all these are very important. All right. So, considerations. Obviously, prevention is the key. Treat aggressively, go initially slow, but progressively aggressive, making people better. And again, scarring can be a problem with patients not presenting to us early, or sometimes the parents getting in the way. So sometimes I see, obviously, the best thing is for the patient to be on isotretinoin. The parent is saying, no, I don't want that drug. You have to explore it and basically find out what there are reasons for not having this great drug to make people better. And sometimes what I do is I'd say, all right, we'll go with what you want. You want to just have an oral antibiotic, want to have a topical, and we'll treat that way for 3 months. I'm going to have you come back in 3 months, and we're going to talk about it again, because I want to prevent your child or your young adult having the acne scarring. So I have a polling question here. And again, facial acne scarring occurs in 65, 85, 95, 100% of cases. And we'll let the people vote and see what they say. Let's see if everybody was listening well. I think I said this a couple times. And can we see the results there? Okay, well, it's a split. All right, the answer is 95%, up to 95%. And I often tell people, I kind of lie a little bit because 95, 100, I often tell people, if we don't treat your acne, 100% you're going to get some acne scarring. And so I'm pretty much close to that, but 95% is what's been given in the results. So now I'm going to pass it over. So I've talked about prevention, but obviously, some of the patients don't get to us on time. Some of the patients are undertreated by their family doctors or other dermatologists even. And so we have to deal with these scars. And as much as we're good at treating acne, sometimes it's difficult to treat the sequelae of the acne, both the dyschromia, particularly in darker skinned individuals, and also the scars themselves. So Dr. Yadav is an excellent dermatologist in Toronto, deals with a lot of these patients that have acne scarring and other things. Edith, like myself, has many different interests, but one of her interests is in acne and treating acne scarring. Who better than Dr. Yadav to tell us? Dr. Yadav.
Thank you so much, Dr. Lind. That's a super generous introduction. And thanks to everybody for joining us this evening to talk about a topic that's actually near and dear to my heart, because I think it is that sequelae that can be so upsetting for patients. And there's a lot of expectation management in scar treatment, because frankly, it's really hard to give people back that skin that they kind of envisioned or imagined or had before a breakout started. So let me just advance some of my slides here. All right, so acne scarring and post-inflammatory hyperpigmentation is what we're focusing on. I want to cover the different types of acne scarring and then go over some of the different modalities of treatment, including different procedures, some energy-based devices, and topical treatments. All right, so as Dr. Lind established, 5.6 million Canadians have acne. It's a huge proportion of our population, and it's estimated to affect about 10% of the global population. It's the world's 8th most prevalent disease, and that we see a large majority of patients between the ages of 12 and 24 suffering from acne. And I think it's important to recognize that it's not just patients who are in their adolescent years, but also who are young adults and who are maybe entering the workplace for the first time, and how acne can really be sort of it can impact them significantly in terms of their employability and their confidence when they go into those kind of settings. 76% of adult cases are in women, and that's also pretty significant. I think it's, I like to tell my female patients that doesn't just extend into 20s, sometimes 30s, but also that perimenopausal time. That's a really challenging time for some women for acne, because they can get flares of acne, or they can have acne for the first time around that time period of their life. Most cases, almost all cases, affect the face, but it is important to ask patients about the trunk and the back, because half of patients report truncal acne affecting the back and chest. And again, Dr. Lind focused a lot on the importance of early treatment, but also appropriate treatment when you have widespread disease. It's very difficult to get a topical medication on your chest and your back. And so if I always make a point of asking my patients, do you get it on your chest and your back? That's a good screening question to kind of see which bucket they're going to go in terms of treatment options. All right, so we'll jump right into the burden of acne sequelae. So patients think about all of these things as scarring, but they're a bit different because you have to treat them a little bit differently. And it's kind of hard when patients just want the one-stop shop, but you have to address these things with different modalities. So 95% of patients with acne will develop scarring. The most common is atrophic, but it can be hypertrophic as well, so above the skin plane, the epidermal plane. The delay of treatment is a key modifiable risk factor in terms of scarring. There's also post-inflammatory hyperpigmentation, more common in patients with type 4 or 5 skin or 6 skin, patients with more melanated skin. So prevention really is the goal of treatment. You really want to get at the underlying cause. And even if you're going to undergo cosmetic treatments, and I will go into this a little bit further into my talk, but I really do tell patients we should just get the acne under control, because there's no point in spending all this money on cosmetic treatments for the hyperpigmentation if you're going to keep developing new lesions and therefore new hyperpigmentation. And then there's also post-inflammatory erythema. So this is more likely to occur in patients with lighter skin tone, and this consists of redness caused by widened blood vessels. I usually tell patients who do suffer from post-inflammatory erythema that even after we treat the acne, the redness is often the last thing to fade. So just to go into a little bit on the pathogenesis of acne scarring. So the majority of acne scars are atrophic. So atrophic is the dermatologic term for thinning of the skin. It's when you get the depressions in the skin from the loss of appropriate organization of the collagen. And so you can get these ice pick scars where they're narrow, less than 2 millimeters. You can get rolling scars that are wider and shallower. And it's important because you can't use the same treatments for both of these. You could worsen rolling or boxcar scars with certain treatments. So it's important to be able to identify what you're referring to. So boxcar is even wider at the base than ice pick, and they don't taper. So it can be shallow or deep, but they're generally sort of more of a square sort of shape is the way we kind of think about it. The minority are keloidal or hypertrophic. And again, it's more common in patients who have more melanated skin. And, even after the acne lesion resolves, you can end up with hypertrophic or keloidal scars that are either red or brown or white. So erythematous, hyperpigmented, or hypopigmented. And the way you're going to approach those is a bit different, again, because the treatment solutions here are different. All right, so here's just an image of different types of scars. So we have ice pick scars, so those are those narrow ones. Boxcar, you can see, are a little bit wider. Rolling scars, that can be very shallow. And keloidal scars, and with rolling scars, you sometimes can't really see the endpoints of them. And then keloidal scars, which are raised. And they act like keloids as well, in which, it's tempting sometimes to think, well, I can just excise that, because that is one of the treatments that we'll talk about, but they will recur the same way keloids tend to without additional treatment. So, all right, a polling question for everybody. I don't know why that didn't work. Okay. Oh, there we go. Okay, so a patient with type 5 skin has just finished 6 months of isotretinoin. Acne scar treatment can safely begin at when? No delay, 1 month delay, 2 months, 4 months, 6 months. How long do you wait after a patient finishes their isotretinoin before you start acne scar treatment? Okay, I like it. Okay, the audience. So 40% of people saying no delay. It's interesting to see the spread. Definitely some folks on the earlier side, the majority, and then a handful with the 6 months. And not just a handful, actually, probably a third, right? So where does that come from? And I hear you on that. So let's go back to this. So it was traditionally thought, because of some really just a handful of studies and some not great study design, that you would have to delay acne scar treatment by 6 months if you were going to put somebody on isotretinoin. But in 2017, I believe, this JAMA Dermatology review basically the authors looked at and provided consensus recommendations on the timing of procedural interventions after completing isotretinoin. And basically, the conclusions were, sorry. You know, so what did they do? They had a panel of national experts in pediatric dermatology, procedural and cosmetic dermatology, plastic surgery. So all these experts, they came together and they looked at all the different sort of treatments in terms of search terms: isotretinoin, Accutane, retinoids, acitretin, and then they looked at search terms like surgery, surgical, laser, and they basically sort of came back with this conclusion. They said 32 relevant publications reported 1,485 procedures. There's insufficient evidence to support the delaying of manual dermabrasion, superficial chemical peels, cutaneous surgery, laser hair removal, and fractional ablative and non-ablative procedures. Basically saying that based on the available literature, delaying treatment isn't necessary. However, caution with mechanical dermabrasion and fully ablative lasers. Those are not recommended in the setting of systemic isotretinoin treatment. So I think the old adage that patients should have to wait, we know that scars remodel best in their early stages of healing, so in the first few months. And so you really do, the patient benefits significantly from doing combination treatments rather than waiting entirely, because patients will clear from their acne on oral isotretinoin before they're necessarily completed their therapeutic course. Obviously, patients have to be able to tolerate both of those things at the same time, because oral isotretinoin can be quite drying. So you have to kind of have that conversation with them, and you may do it at the beginning of the treatment when you're titrating up the dosing for oral isotretinoin. Okay, so going into procedures. All right, chemical peels. So there's a variety of chemical peels that get used. I use different compounding pharmacies to make them for me. You've got, you know, variations with resorcinol, salicylic acid. Salicylic acid is a beta hydroxy acid that can, that's sort of oil soluble, so it can help penetrate into the pore, and it can also help decongest pores and help with cellular turnover, keratin turnover. Lactic acid or stronger glycolic acid. Glycolic acid 30% peels are kind of standard fare. I think that most patients can find. We tend to go up in the acne, in the chemical peels that we do for our patients. We'll do at least a Jesner's peel, so something a little bit stronger that has a combination of resorcinol as well as other agents. And incorporating fruit acids or retinoic acids with home regimens can help boost the efficacy of a chemical peel. This is probably one of the most superficial treatments, probably one of the safest things you can do in all skin types and skin colors. And just to be mindful that if you're going to put somebody down a pathway of chemical peels, they really do require multiple successive treatments. So they need like 6 treatments 4 weeks apart, you know, or 2 to 4 weeks apart. Like you have to stack them. That's how they're going to get the best benefit. And it's just not going to be a result for them with one treatment. And what's really important, if you do practice cosmetics, that you want to be able to take very good before and after photos so patients can see the change, because it is gradual, especially when you're dealing with hyperpigmentation, which I find chemical peels to be the best for. So this is just a categorical overview of chemical peels. You can see that superficial chemical peels really go into the stratum corneum or the stratum basale or the upper papillary dermis. And so I mentioned that in my practice, I often do Jesner's peels, but you can also do 35% TCA, salicylic acid peels, like 15%. If you want to do a medium peel, you know, you have to be just a bit mindful and careful of the pain and the tolerance that that patient has, but you're talking about doing these combinations with TCA and glycolic acid. And then obviously going into deep reticular dermis, these are peels that require cardiac monitoring when you do them, because they can be absorbed systemically. But ultimately, you can see that, you know, when you're treating also a large area, you have to be very mindful the deeper you go and the risk of scarring. So the benefit can be greater, but so can the risk. So this is an example of one of my patients that had 5 treatments with a Jesner's peel on the back. And this was acne that had been stable and stuck for over a year. And so then we proceeded with booking him for a series of peels, because that large surface area is very challenging to treat. I would say this is a well above average outcome. I don't show this to patients so that I can sort of promise them this, because this is like a very abnormally good outcome, but it shows you how effective even a superficial, relatively superficial treatment can be, and how that's probably one of the most practical approaches you can take on a large surface area. So TCA cross, it's another way of using, so trichloroacetic acid. It comes in many concentrations. When you're applying it all over the face, you know, we're using generally lower concentrations, like 35%. But when you use it in the ice pick scars specifically, you want to go to higher concentrations. Some of my colleagues do 90% TCA. I sort of tap out at around 75 or 80. It just depends. But, you know, you are going to need multiple treatments. The peel depth varies according to the concentration of what you have compounded. Higher concentrations can obviously reach deeper depths. It is self-neutralizing and it's not systemically absorbed, so there's safety in being able to go to that high concentration. And cross is this technique where you basically do that high concentration of TCA focally by pressing a sharpened wooden applicator on the entire depressed area of the scar. So this is an example of the kind of frosting that you would see when you do that TCA application. And you really have to be mindful that you don't do it on boxcar or rolling scars, because you can widen the scars, you can widen their appearance. So this is really a technique that's very specific for ice pick scars. All right, so there are also a variety of punch techniques. So punch extension, punch elevation, and punch replacement. Punch removal or punch extension is generally probably one of the simplest things to do, but the idea that you can, if I see a patient with sometimes keloidal acne and they're not responding to, keloidal scarring from their acne, and they're not responding to intralesional Kenalog, which everybody should try first and foremost for that kind of hypertrophic scarring, you can do a punch removal, but you have to still treat with intralesional Kenalog. Also, if you have deep scarring that no chemical peel is going to fix, or if you've got type 5 or type 6 skin, you know, you might be risking more scarring and pigmentary abnormalities by using a chemical peel or other lasers to the degree that you need to use them to, then a punch technique can actually just cut out the scar, give those denuded edges and get them to go together. I'd be less inclined to do this on an area like the back, because those areas don't heal as well. But on the face is very forgiving. It's highly vascular. Punch technique can be very helpful for patients who have depressed significant scars to try to even out the skin. And then you've also got subcision. So classically, and there's been different publications on efficacy, but you could use a no-core 18-gauge needle. So that basically looks like an arrowhead with just one side on the tip of the needle, and the sharpened end is on that angle of the triangle. And what you do is you insert into the skin and you run in parallel to the skin surface. So you can basically create a nidus for collagen formation, because what you're doing is you're causing blood to pool, and that is that spacer that you need to kind of separate those tethered adhesions of scarring. And then also it's almost like doing deep PRP, if that makes sense, where you're trying to like stimulate all these growth factors, all these healing factors by creating trauma deep under the skin and encouraging a regenerative process where the collagen will organize itself a lot better. You may, that may require multiple treatments. You can also do subcision with a cannula. So you can take a cannula, and if you do any collagen stimulators in your practice, and we'll talk a little bit about that at the last end, but you can use that and use the cannula as a form of, in a technique to kind of subsize. You could also do it with just saline, which is quite safe, and you can then enter into the plane. And again, it's mixed literature on which technique is better, but certainly I find subsizing first and then doing TCA cross on top is a nice combination for patients, so that you can kind of try to lift up those scars a little bit and then do the treatment on the epidermis. Here's a graphic of subcision performed with an 18-gauge no-core needle. And so again, you can see that sort of blade. The blade should be parallel to the skin surface. And what you're trying to do is elevate the scar by severing some of those fibrous bands that are underneath, but also by creating, again, that blood cushion that will also help with regeneration of the collagen. So moving on now to energy-based devices, and then we'll have a chance to ask questions for sure. So energy-based devices, just a quick overview of the lasers that are available for acne scarring. So you've got a variety of laser platforms. Generally, the way to think about it is ablative and non-ablative. And ablative means that you're going through the epidermis and causing damage to the epidermis, whereas non-ablative doesn't do that. And so you can have fractionated and not fractionated in each of those categories. Generally speaking, ablative, not fractional, is not used commonly anymore because there's a significant amount of downtime for the patient and risk of scarring and dyspigmentation, and it's not an easy thing to do in different skin types. So we use non-ablative fractional as well as ablative fractional in my practice to resurface patients, and that means that you're heating the skin in these micro columns, and the fractionated component means that you're leaving intact skin between those micro columns, and that again helps stem cells and growth factors migrate from healthy tissue to help support the healing of these micro columns that you've created, and therefore overall improving the texture of the skin without that significant downtime that you would get if you were kind of denuding the entire surface. There are other lasers listed here that are described as non-ablative, non-fractional, and those are actually vascular lasers and or pigmentary lasers. So just to highlight out a couple of them, at the bottom, you've got picosecond lasers, which use almost their energy at an acoustic level to be able to break up pigmentation in the skin and encourage its metabolism. So I do that for patients, especially who have type 4, 5, 6 skin and who have hyperpigmentation, though that pigmentation tends to be deep. And so again, lasers are not exactly like a panacea for hyperpigmentation. It really is prevention, which is the key, because oftentimes it's very hard to improve that. There's also pulsed dye lasers mentioned here and KTP. So those wavelengths target vascular components. So again, if you have that post-inflammatory erythema, that redness after you've had acne, your patient has that redness, you can use a vascular laser to help improve that color. That post-inflammatory erythema generally improves on its own with time. It does depend on the patient, but if they want to help encourage that healing along, then you can certainly treat it. This is an example of one of my patients with type 5 skin that I treated with non-ablative fractionated resurfacing. So I used a Fraxel Dual on this patient, and you can see that he had, again, a variety of ice pick scarring around the temple and the cheek, and you can see the improvement overall in texture. But again, I consider this this is a great result. And also you can see his pigmentation has significantly evened out. There is a bit of a color difference in the two images, but that you can see that there isn't that hyperpigmentation. It's a great result. It's not an average result though. And I wish I could say it was. So I really would much rather, again, patients come to me and they'll say, it's sad. They'll say, I wish I had gone, somebody told me to go on Accutane, that's colloquially, we use the word Accutane the same way we use the word Botox, right? Like everyone just kind of says it like Kleenex or, but when we're referring to different medications. And so, patients will say, gosh, I was told I should have used Accutane 10 years ago, but I didn't. And so now I kind of regret that. And it's just really hard because in that moment, you get some skepticism from your patients about going on systemic treatment. There's a lot of baggage that people read about on the internet, but they don't kind of realize how difficult the outcomes are going to be to manage down the road, and frankly, how costly it's going to be for them to manage. So anyways, but I'm not all doom and gloom. I wanted you to see a nice outcome with one of my very nice, lovely patients. This is another example of a patient that was treated with erythematous boxcar scars with pulsed dye lasers. So again, a vascular laser. You can see some of the settings below. And sometimes that discoloration accentuates the uneven quality of the skin. And so that's something to be mindful of, that improving the color generally evens the complexion, even if it's not necessarily changing the scarring. But there's evidence to say that actually pulsed dye lasers work very well to also help remodeling post-Mohs, so when you've got skin cancer surgery on the face, that the vascular lasers play a role in scar remodeling. So there's a chance that that's how they're working in acne as well, not just on the red component or the vessel component. Here's another patient that we treated with a Pico Pro laser. So it's if you look at her left cheek and her forehead, you can see the improvement in that pigmentation. Now, this is not from acne scarring, and so the pigment in this patient is much more epidermal. It's much more superficial, so it's much easier to treat. But I wanted to give you an example of how in one treatment you're not erasing everything. That's no way. Like, you know, you have to tell patients it's a series of treatments, you know, if they want to get a realistic outcome, and you really don't want to kind of overpromise. You actually kind of want to lower their expectations, because again, these, especially when the pigment is deeper post acne, it can be very hard to turn over. Okay, so I'll touch a bit on fillers. So there's different types of dermal fillers. You've got short-lasting fillers, which are hyaluronic acid fillers, which is probably what 90% of what we inject is. These are made out of collagen that we have in our own kind of system, right? We're all made of collagen. Babies are filled with it, which is why they look so perfect and circular. And hyaluronic acid fillers, though they're metabolized by our own bodies, and depending on where you inject the filler and the kind of filler, how cross-linked it is, can determine how long it lasts in the skin and the role that it plays. So you want something that's a little bit more collagen stimulating. You can call them semi-permanent fillers because that you can't really dissolve them. They do integrate into the tissue, but obviously they don't last forever and people are still aging. But there are two biostimulatory agents on the market, and they come as poly-L-lactic acid, which is Sculptra, or calcium hydroxyl apatite, which is Radiesse. Those are the two that are on the market right now to create basically collagen stimulation. So they encourage the fibroblasts. They create a matrix for the fibroblasts to be able to generate more collagen. And obviously a patient's ability to create collagen changes as they age. So 25-year-old's ability to create collagen is vastly different than a 45-year-old's ability to create collagen. And so the number of treatments that patients need, again, varies by their age, by their skin quality, their sun exposure, all these things. And so when you add scarring into the mix, it does create a real challenge. But I truly find that for patients with acne scarring who really want to improve their skin quality, they need to go for these combination or multimodal kind of treatments. I think the other way for those that don't inject Sculptra, but who are sort of curious about this, you know, collagen stimulation, what is this? I think one of my dear friends and colleagues, Dr. Kusipon, this is her analogy, so I need to give her credit for it. But she talks a lot about how when you look at a lawn and you see like sort of grass dying in your lawn and you sprinkle grass seeds on your lawn. So think of your face like that just as you age and you get these like dying patches of grass. And so what these collagen stimulators are, it's like sprinkling grass seeds back on the lawn. And in the setting of acne scarring, what you're trying to do is get that collagen to remodel, to be able to create the appropriate mix of collagen so you end up with a better, not just the scarring in terms of the texture, but also the skin quality itself, the luminosity of the skin, everything that gets altered from scarring. And then you've got polymethyl methacrylate, which is a permanent filler. I don't know any colleagues that are injecting it. Permanent fillers, no, don't do them. I mean, they can migrate over time, and I've seen a lot of complications from that. And then there's thread lifting. So Health Canada approved on the market. There are these poly-L-lactic acid threads that you can insert. They have an angle that basically goes from, you know, temple to nasolabial fold, and the idea is that you can create sort of a little bit more less laxity in the skin by inserting these threads that anchor in the skin. And because they're made of poly-L-lactic acid, there's been some evidence to show they also can help stimulate collagen and therefore improve with skin quality and texture in the setting of acne scarring specifically. And so lastly, and then we'll have time for questions, is combination treatment. So I wanted to hone in a little bit on isotretinoin and topical retinoids too, just for that matter. There is no real topical agent that we know of that improves scarring the way a topical retinoid does. And by the same token, you can get improvement with scarring from oral treatment as well. So what does oral isotretinoin do? It's the same as topical, but it just does it kind of better, more effectively. It's more potent. Therefore, you get a bigger benefit, but you also get bigger side effect profiles. So you have to kind of manage that with patients. So you get the involution of the pilosebaceous unit. So it involutes. You decrease acne lesions and related scarring, and you decrease associated symptoms of anxiety and depression. And I always tell people that my happiest patients are my isotretinoin patients. Like, I can't do this for everybody. You know, what I can do for patients when I treat their acne with isotretinoin, because it's not forever, you know, it's like for a finite period of time for most patients. And then, you know, as I talked about at the beginning, since 2017 and that review, multiple studies have found that various energy-based devices, including vascular lasers, non-ablative fractional lasers, and 1064, which deals with pigment, they're safe and effective for acne and acne scarring, either in combination with isotretinoin or starting within 1 month of completing isotretinoin. So it really is about the patient's tolerability, but I think this is the sweet spot. I often see patients coming to me and they want to talk about their scarring first. They're so concerned about their scarring, and they don't kind of realize the role that treatment and prevention play in making that scarring journey better on the whole. And even after I complete isotretinoin treatment for patients, I usually put them on topical retinoids as part of their maintenance regimen, again, to help with scarring and also to help with hyperpigmentation. So here's a couple of, a bit of a summary of some of the combination treatments that I've published in the literature. So combining 1550, so that would be a fractionated ablative laser, so 1550 nanometers with TCA, so trichloroacetic acid, and subcision for atrophic or ice pick scars. So 3 to 4 treatments with laser, 4 passes, 2 weeks after the laser, then the peel was done, and subcision at the same time, and that was repeated at 2-month intervals. And in this study, the findings were that the mean scar severity scores decreased to 34.8 compared to 80, and that's just the scale that they used. So more than 50% improvement from baseline. And patients reported significant improvement and no complications. Another combination treatment is using CO2. So that's, again, ablative laser, and you can get that fractionated or not fractionated, but CO2, again, trichloroacetic acid and subcision, again, looking at a mean improvement of 2.9 on a different kind of scale. There's also 1450, which is, again, in the kind of resurfacing family, 30% TCA, 4 monthly laser treatments. And part of the reason is because you want to be able to kind of stagger and stack the wound healing that's happening to be able to make those treatments a bit synergistic rather than these standalone things. And then again, there was a split face that was done looking at CO2 or CO2 plus topical application of this ADSC compound. And again, subject satisfaction and increased elasticity and decreased roughness. So summary here is that clinical efficacy of acne scar treatments by scar subtype. I modified, oh no, this one I haven't modified. This is straight from an article in the Clinical Journal of Cosmetic Investigative Dermatology, but just to kind of go over it, basically, chemical peels you can use for all types of scars. That's what CP stands for, whether it's ice pick, deep, shallow, or rolling. You can use dermabrasion, again, on all of them, but dermabrasion doesn't really go deep enough, which is why it's better for shallow boxcar scarring. You can use microdermabrasion. Again, it's a bit more of a shallow treatment. Subcision is really great for rolling scars or deep boxcar scars. That's when you go in underneath with a no-core or a cannula to try to release those tethers, again, create a bit of the blood pooling in space between the layers of the tissue and encourage collagen remodeling. Microneedling, again, good for shallow boxcar and rolling, but microneedling, again, in the office goes deeper. At home, treatments it won't go deep enough to really create a meaningful difference for patients. punch excision, that's for deep boxcar scars. I would also say it's for deep ice pick scars that won't resolve. So, but deep boxcar is the indication here. And then filler, you can really use on all of them. I think it's important to note that actually I've had some interesting success using, there's a rebrand of a filler that was called Volite by Juvederm, and they've rebranded it as Skin Vive. Restylane makes one called Skin Boosters, and these are kind of very low, low density fillers, more like 17 milligrams per ml, as opposed to their high density for cheek and volume and lift. And so you can inject these like micro aliquots of hyaluronic acid into the skin at multiple points, and then induce sort of a more even skin tone in patients that do have that kind of undulating, rolling acne scar profile. And so that's the overview of all those treatments, mostly looking at scarring, a little bit at hyper and pigmentation and erythema. The last thing I'll just say is for hypopigmentation, I didn't spend a lot of time on it, but an interesting solution there is there's been some studies, and I've done this in my patients using bimatoprost topically or Latisse, because one of the side effects of Latisse is that it can cause hyperpigmentation along the lash line where it's applied. So you can do Latisse with microneedling, and you can induce pigmentation, and it's an even pigmentation, not like a patchy, weird pigmentation in hypopigmented scars. And I've done that for a handful of my patients. So something to kind of keep in mind. I think the main lesson here, though, is that everything that you do is like off-label, and you have to do multiple of them. And so you can like hope that you give your patients a good result, lower their expectations, because this is a challenging thing to treat. But the real best case scenario is truly treating them aggressively initially, so they don't have to go down this road in the first place.
Thank you very much, Dr. Geet. You had a great overview of all the things that you can do to treat the scars. And I think one of the big things I think you really helped us with there was that, in fact, the expectations of the patient, I think, is extremely important, because once they have these scars, we're not miracle workers for the most part. We can improve things. So I think that's really trying to undersell things. And sometimes you're lucky. You get a fantastic result like you've shown. So that's good. All right. So I'm going to talk about a little bit here. So prevent the scarring. And I think that's the message tonight. We can do all these different modalities and everything else, but we're not always fantastic doing things. Even Dr. Yedev, who does a lot of this, is quite humble in telling you that she can't fix everything. She tries, and I think that she's very honest with her patients. But preventive scarring is part of the message tonight. Treat it as early as possible. Treat aggressively. Don't be afraid to use your big guns. Get the isotretinoin. It's a fantastic drug that has helped so many patients. Oftentimes, I'm just out in the mall, or we're shopping or something, and somebody comes up and says, you changed my life. My trajectory of my life changed because of you, Dr. Lynn, and because I had put them on isotretinoin at some point. My wife says, who was that? And I go, I don't know how that, I don't remember, but I obviously made a difference to that person's life. And that's what we do in dermatology. We make people's lives, quality of life, much better. And this certainly is a drug that does that. There are certainly all the number of treatment options. So treat the acne. You have many different options here. And so there are different, and we often combine options of both topical and systemic. And these are some of the things that are on the market. And as I mentioned, we're highlighting the use of isotretinoin tonight, but there are other options we can sometimes use. Combined oral contraceptives, spironolactone, different antibiotics. Must admit, in my office, I don't use a lot of minocycline. I found that sometimes people get hyperpigmentation because of the minocycline. And of course, there are rare reactions of hepatitis. So I think most dermatologists are shying away from using minocycline anymore. So isotretinoin is the gold standard for treating a lot of our acne. It's been in Canada for almost 40 years, basically. 1982 FDA approval in the United States, 1983 in Health Canada. It's reliable, consistent, and it works on all varieties of acne and skin types. This is actually one of the first, I do a lot of clinical research. This is actually one of the first drugs I was involved in the clinical studies in looking at isotretinoin back in 1982-83. Now, like anything, Tide or anything else, you can always improve things. So the old Accutane isotretinoin basically had to always use with a very fatty meal. This is what they did in the clinical studies. And most people don't eat. I must admit, I still do, but I mustn't. But this is the type of thing, and most people don't eat this type of meal. Bacon, eggs, some potatoes, butter on toast. And in fact, a lot of our patients are adolescents, and about a third of those patients skip breakfast. They don't have breakfast at all. So they're obviously not having a fatty meal. They're young, consume ready-to-eat cereals, and they don't have these fatty meals, right? So if you can do something that addresses this, provides within the isotretinoin the kind of fattiness, if you would, and this is the Lidose technology that's come along. And this is found in one of the particular isotretinoins that most dermatologists use now quite extensively. And most of us are not using the older Accutane because this provides better safety and better efficacy and can be fed or unfed in terms of helping people. And this is the technology, this Lidose technology. Fatty meals without dairy. If you want to try other things, you can use peanut butter, avocado. You can add a little bit of eggs and even a little bit of meat. But these are the studies that showed that the purest type of isotretinoin in fasted state, non-fasted state, demonstrated that it's reliably absorbed in both of this, fasted or non-fasted. And so you're getting the drug to the person, particularly those teenagers that don't eat any of the fatty things. They skip the meals. As I mentioned, a third of them don't even bother having breakfast. So they're obviously not having the fat that's necessary for the older isotretinoin, the Accutane, to be absorbed. Also, just to note, there was Cunliffe and everybody else suggested that you had to have a magic number of 120 milligrams per kilogram over usually this translated into about a 6-month period. This allows individualized dosing. It comes in 10, 20, 30s, and 40s. So you don't have to be using use 2 40s one day and 140 the next day, or use, different dosing. You can make a dosing easy for the patient to do. So I'll end with what our message tonight is: prevent, 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 so you don't have to treat. And that's the message for tonight. So remember that. And I think we've got time for questions. Roxanne,
Sure. Yeah.
do you have some questions that come in from the chat?
Yeah, and remember, if you want to write any questions, please put it in the question chat pane. We'd like to, again, thank our supporters, Cipher Pharmaceutical, for making this educational event possible. So we have a couple of questions. One question is directed to Dr. Yadav. You're given us several options for treating scarring. Which ones do you have the most success with?
It's such a complicated thing to treat acne scarring that I would say, and it depends on the patient, the kind of scarring they have, and the type of skin that they have. I would say, doing chemical peels is something that pretty much everyone usually can tolerate and benefit from. Is it going to get patients exactly where they want to go? Not necessarily. Certainly, I wouldn't do that for hypertrophic scarring, but I would say if you were kind of looking for like one thing for patients to try, I would say chemical peels are pretty safe in all skin types. But if it's severe, it wouldn't be sufficient.
I think, correct me if I'm wrong, but I think you have to use many of the modalities because there may be areas, you need to throw many of the things at them, and one thing doesn't fit everybody. You don't just go, oh, let's do a chemical peel,
That's right.
I
No,
think
I mean, it's sort of like if you're part of it is also, I think, you make a good point. It is a journey, right? Because even if you are going to do multimodal things, which ideally you would, but obviously it depends on the patient's like budget, appetite for downtime. There's a whole bunch of things, risk. And so if you're going to do that, it's not going to all happen tomorrow. So, I think what's important is like you start patients down a journey where ideally you give them some hope and optimism in the results and the outcome. And that's part of why you're very right, Chuck. Like it's like if I see somebody with severe acne scarring, I'm not going to suggest a chemical peel. I'm going to suggest laser resurfacing. And if they're really insistent on a chemical peel, then it's very clear that that's not what I would have suggested as first line given the severity of their condition. So yeah, it's very hard to say. It's sort of like that may be the lowest common denominator, but it may do nothing.
and this is a perfect example of individualized medicine, right? Every patient is different. You look at them and you go, I think that's going to work. That's not going to work. And you have to look at throwing a number of things. I think also treating relatively early, it is a journey, but again, people are concerned about this and they are asking about it. And you strike when the iron is hot, don't you? You treated them, you got them better with, say, the isotretinoin or whatever modalities you have. And now you're addressing what they really came for, because every time they came to you, they came because they wanted the scarring gone, didn't they? Way back. But you said, well, plan A, let's get rid of the acne first, right? And then plan B, now we're going to address this. You can't say, oh, come back 3 years from now, let's see if it's all gone away. Because they want to have treatment now.
Yeah, I think it's a really good point. And I think in this era too, where you've got a lot of people who are like staring at themselves on screens, it's important to be able to kind of those needs.
And they're getting all their advice from this too, aren't they?
So another question.
So many dermatologists out there on this that trump all the degrees that you and I have. Roxanne, you got
another question was, I've seen good results with microneedling in many patients. Is there a reason this was not discussed?
No, I did mention it actually. It shows, I mentioned it in my summary table. And again, and I talked a little bit about the depth. So you can do microneedling for, superficial or scars, but, or for hyperpigmentation, it can be helpful. I would suggest in office microneedling where the needle depth is a bit deeper than at home microneedling, because those devices also exist. No, so I did mention it in some of the summary tables. Maybe that was just missed somewhere.
So also, Gita, good point. Most of these things that are really going to work are in the office, right?
Yeah.
I gotta tell people, you've got all these things. You can go online, you can buy all kinds of things on Amazon and everything else, but you need an expert such as yourself or many other dermatologists, obviously, to be able to direct that care, because they're not, much as they think they've gone to university and become dermatologists, they're truly not. And so they want our guidance and our help in this. And we want to be able to direct them and give them the best results, rather than them trying their home microneedling and then they come to see you and you say, I want to give you microneedling. Oh, I've already done that. It wasn't effective.
Yeah, and actually going back to that concept of chemical peel, there's so many home peels that people do, and then they end up causing themselves like an eczema or dermatitis, and then they end up with more post-inflammatory pigmentation problems from the inflammation from the treatments that they did at home. Like I see a lot of that. There's a real desire to sort of try to remedy this, but it can cause a lot of complexity, and acne scarring is so challenging. It really is like deep, for almost everybody. Yeah, I echo that for sure.
So another question is, isotretinoin has evolved. Is there so much better using lipo technology for patients?
Yeah, I'll answer that. I mean, I kind of briefly said it at the end there. That has made it, and that's why I think most dermatologists have gone to the more advanced types of isotretinoin, particularly Epuris, because you want to be able to get the drug into the body and to be able to provide the benefit that you want. It's a bit hit and miss. As I mentioned, most people are not taking those big fatty meals with their Accutane. And that's one of the things I think more and more family doctors are using isotretinoin, and they're potentially using just the brand name, quotation marks, the older Accutane, and then they're not talking to them about, you got to have a fatty meal, a really big fatty meal, for this to be absorbed and get in there and do the benefit that you want. So a number of times I've seen patients, they've been on one low dose Accutane, 10 milligrams, they've had it for 2 months, they didn't have it with fat, and they come and go, isotretinoin didn't work for me. Well, they didn't really use it, actually.
I think that's such a good point, because I also, now we're also seeing that the therapeutic dose range can actually be pretty wide for patients with oral treatment. And as a result, if you're not getting the full drug absorbed when you're taking it, I think you're just also, even if the patient ends up being clear and you finish their course, their risk of relapse is going to be higher, because they may not have gotten the amount of drug that you think you gave them, or that you think they got, because it wasn't absorbed properly. And so it can also drag out a treatment course, and you're sort of like, oh, and then you reach this maximum therapeutic dose window. Like, it adds complexity. So ideally, you want to be able to make sure that the dose and the drug you're giving the patient is exactly what they're actually getting. And this just brings us closer to that harmony.
Good points, Keita. Roxanne?
Well, that's all the time we have today. So thank you so much, Dr. Lin and Dr. Yadav, for an insightful presentation to a really challenging issue for patients. And we'd like to thank you all for joining us this evening. Good night, everybody.
Good night, everybody. Thanks, Keita. Have a good one.
You too. Bye.
Night, Roxanne. Bye-bye.
Bye.